without further ado, having the chance to really speak to, I call him the godfather of shockwave medical therapy, because he really was at the forefront for bringing this technology to more doctors and to more people. And he realized that there were so many skeptics and people that didn't believe in this process or this type of therapy, that he very early on realized that they needed to have the research behind it, and is one of the founding members of the International Shockwave Medical Society. So without further ado, Dr. Wolfgang, why don't you take it over and give us a little history?
Thank you for your nice presentation. I started to be extremely skeptic. I'm a surgeon, I'm a trauma surgeon, and the very first study I performed using shockwaves for non-healing fractures was to prove that it won't work. And in this study, I just collected 50 patients and applied shockwaves, and these were the worst of the worst cases around, from 20 clinics that sent their patients, and 25 out of them healed. And so this was like a miracle. And this was the reason for I started to get closer and to try to understand more of this technology. So I will share my knowledge concerning working mechanism of action of shock waves. But to start with, I think it might be good to have a couple of slides of physics to make understand what we are doing. So here you see the typical profile of a shock wave. There is an extremely quick pressure raise. Within 2 to 3 nanoseconds, we reach up to 400 bars that we deliver into the body. Then after each shock wave, we have a negative pressure, which is a tensile force. Till today, we are not really aware which property of the shock wave is responsible for the biological effects that we are creating. So just to give you an idea, this is the shock wave. And when we have a tissue, the shock wave is oops, sorry. This should, wait a minute. Yeah. So here you see the shock wave arrives, and there is the compression of the cells of the tissue. Then when there is the negative, the traction forces, we have an extension, and then we come back to the origin. And this happens with each single pulse traveling through the tissue. When we speak about shock waves, there are 3 possibilities to create such a shock wave. One is the electrohydraulic system, the oldest, and that's the one that we use with the gamma gold, ortho gold. Then there is the piezoelectric. Here you have piezoelectric crystals that send their pressure waves, and only in the focal area they form a real shock wave. And the same is true for the electromagnetic wave. Here we have a membrane. We first create a flat shock wave, and then through an optical lens we focus it, and the same is possible with a cylindric source, not just a membrane. So here you would see how such a piezoelectric source would work, and be conscious of that, you only have in the focal area you have a shock wave. All the other parts are pressure waves. Here you see electromagnetic system, and the same is true. So when you imagine, here is the therapy head, so there is a pressure wave traveling in the tissue, and only in the focal area they form the typical shock wave. Here, this is a old, but this shows you the lateral directions, 1 millimeter. Even here, this is just pressure waves. Also in the axial direction, only in the focal area, these sources piezoelectric and electromagnetic form shock waves. This is very different to the electrohydraulic system. Here you see such a spark plug. And when you put an electrical tension in water, there is a spark developing. The shock wave is developing that quickly that you just don't see it by using a camera with 100,000 pictures per second. You need 5 million pictures per second. Here between these two pictures, here you see the spark developing, and this is the shock wave front, which is of course developing spherically. So this is what would happen when you just create a shock wave without reflector. When you put this in an ellipsoid, you have a focal area. And what is the main issue of electrohydraulic system is that you have a a priori wave. This is a shock wave already that is developing spherically and followed by a focal shock wave. So this is the main difference between the devices. So when we speak,
this is where John always says we're the only medical device company in the world that has a primary and a secondary sound wave, correct?
And from the clinical part, we just see that we are more efficient, which means we need less pulses, we need less energy flux densities, and less sessions compared to other devices. We tried, for instance, to use the electromagnetic device for our clinics where we are treating non-healing fractures, pseudarthrosis. And what we would just see, we were not able with a single treatment to get the same results with electromagnetic compared to the electrohydraulic. And here you see how this spark is developing. And as this is creating a plasma channel, we have immediately a shock wave profile of the wave wherever the therapy head touches the skin. And just also to give you an idea, this is a bone treatment with the old Ossatron, which was also a electrohydraulic device. And here you see you have the primary wave and then the focused shock wave. And also for understanding, as the focal area stays the same, it only gets bigger when you increase energy flux density. But now when you move the head down, just your focal area would go into the bed. Yeah, so this is how we can control our focal area. And when we use, instead of an ellipsoid, a parabolic reflector, we can shape the wave. So the more the spark gap is produced in front, the more the shock wave would open. So we can have also a focused shock wave, defocused, or small focused, or gentle focused. And this is now the radial pressure wave, which is a completely different animal. Of course, most of the producers call this shock wave as well. We started now on an international and national scientific community base to call this radial pressure wave, because this is a very simple way to produce the pressure wave. You have compressed air, you accelerate a piston, and here this is the therapy head, you hit it and the energy enters the body. Here we are speaking of a velocity of the wave below 10 meters per second. When we use shock waves, we speak about more than 2,000 meters per second. This is more than sound velocity, double sound velocity almost. So these are really completely different animals. And here,
And
if you would
that one creates trauma. The process you showed with the electrohydraulic, there is using mechanotransduction. There's no trauma or damage to the tissue, correct?
Energy levels that we are using, there is no trauma to the tissue. We just through to the compression, tensile forces, shearing forces, we stimulate genes in the cell. I'll come to that a little bit later. But you are right. This is a mechanical impact. So if the red line would be the skin, depending on the pressure of your therapy head, you have maximum energy deep in the tissue. And when you remove the head, this energy would just come to the superficial area when you treat a tennis elbow, for instance. And when you use radial pressure waves, you have a maximum of pressure on the surface of the skin. And with the square of the diameter, you lose the energy, which means below 5 millimeters, you have practically no pressure that you could measure in the tissue. So this is more a massage. There is good evidence also for some pathologies that you can treat with radial pressure wave. But what I will demonstrate today is only true for shock waves. So why do we use these shock waves that were created to disintegrate kidney stones in other medical fields? This is due to Gerald Haupt that I met 2 years ago for the first time. He's a urologist, and he knew that when destroying ureter stones or bladder stones that are below the kidneys, for same size stones, you need more energy, more pulses to destroy compared to kidney stones. And it was not really clear why this happens. And in those days, you have to know that bladder stones and ureter stones have a high recurrency rate. So it was used to do X-ray controls because in 86, there was not yet the ultrasound developed at this stage, and this was lucky because what he could see is where the shock waves traveled through, there was a thickening in the iliac bone. And this was the first time that it was reported that there is an interaction between shock waves and the biological tissue, in this case, the bone. I was a young trauma surgeon in those days, and I was focused on bone healing. And so for us, it was suddenly perhaps a possibility to stimulate osteogenesis, to stimulate bone growth by using shockwave. And of course, as we had these pictures in our head, we were convinced for the first 10 years using this technology that micro lesions in the bone would be responsible for the new bone formation. This was completely wrong. We have now completely new ideas. And maybe in 10 years, I'll tell you another story, because when you do science, you just learn day by day. So now I want to share with you why we also developed other tissues to be treated by means of shockwave. Here you see an X-ray of a tibia fracture of a 65-year-old male, HIV positive, insulin dependent diabetic. He also had an immunosuppressive therapy, and he got surgical procedure with an unrimmed tibia nail quite nicely in our clinic. But a patient with this medical history has, of course, very little regeneration potential. And so it happened that 3 months later, there was almost no callus formation, and you see the screw broke and the bone didn't heal. At the same time, this was the situation of the skin 3 months after the accident, did not heal at all, and is of course dangerous because this was created by the bone. So there is a connection between the deep layers and the skin. So we applied shockwave, and 3 months later, you see the bone is in a healing process, and after 3 years, there was completely bony healing. At the same time as we used shockwave for the bone, we also treated, of course, the superficial layer, and 2 weeks later, this was closed. We were very afraid that this might explode because it's just superficially closed, but after 3 years, we didn't even see a scar. And so up at this point, we just had to leave our hypothesis that provocation of micro lesions would initiate repairing or healing processes. So what we observed is that when we use lower number of pulses in the bone treatment, because we started with 12,000 pulses in the beginning, because we wanted to create mechanical damage. So we saw that when we use less, 3,000-4,000 pulses, we have even better results. And at the same time, Markus Meyer in Munich, he applied shock waves to femora of rats, and he would find the highest osteogenetic potential and reaction of the bone using energy flux density that did not create any damage, also microscopically, to the bone. So we had a new hypothesis: shockwave treatment can induce biological responses without damaging or destroying the tissue. And one of the pioneers of shockwave history was Jin Cheng Wang from Taiwan, in Kaohsiung in Taiwan. And he treated also with the oscillotron the bone tendon junction of the Achilles tendon in rabbits. And he looked at baseline 1, 4, 8, and 12 weeks to different parameters. One was the number of functioning capillaries. And you see in the control group, in the beginning baseline, you have the same number of vessels. After 4 weeks, you already see a significant difference between the treatment group and the control group, and this stays. And meanwhile, we have over 500 publications that demonstrate that shock wave applied to tissue is angiogenetic. New blood vessels are formed. And this is what he looked also. He looked at VEGF. This is a growth factor responsible for vessel endothelial growth factor for formation of new blood vessels. And he did a single treatment at baseline. And you see after 1 week, there is already significant more VEGF in the tissue compared to the control group, where there is practically no changing. And this stays for 4 to 8 weeks. Only in week 12, it goes down back to baseline. And this is something that has a clinical importance, because shockwave is not a painkiller. Shockwave stimulates biological reactions in the tissue, which means whether you use 1 treatment or 4 treatments or 5 treatments, after your initial session, wait 3 months to see the result and prepare your patient that it takes this time for having the final result. And then after 12 weeks, I tell my patients, for instance, with the Hillspur, with plantar fasciitis, I tell them there are 3 possibilities. 1, up to 90%, you are happy, I am happy, we don't see each other anymore because of your heel. Second is you are significantly better, but not yet completely satisfied because you are a runner. Then you do a second session with 1, 2, 3, or 4 treatments, whatever is your number of sessions. And the third possibility is we didn't see any changing at all, then go back to diagnosis. Then it might be undisplaced fracture of whatever, entrapment of the plantar nerve, but then be critical. And so the patient, after 3 months, they come back, they say, they need a second session, or we have to go for diagnosis, or they just call and say, I'm happy. So this is what we can learn from basic research. So for me personally, shockwave is a form of communication between biological tissue and us, and we call this mechanotransduction, bringing in a mechanical force into a tissue and changing the tissue. And you can communicate with muscles just by, you don't need hormones. I mean, in this case, perhaps hormones are also, but in reality, just by weightlifting every day, 3 times half an hour, after half a year, you can reach this situation. And if you take a biopsy here and here, you will just see that this is completely different tissue. You have more nerve cells, you have different blood vessels, more blood vessels, and you have different muscle cells. This is not more of this. This is different. It's completely different. And this is just by putting in mechanical impact. We know this from the bone metabolism. Here you see an undisplaced fracture of the tibia. Usually this is treated in plaster cast, and the patient is motivated after 3 to 4 weeks to put weight on the leg. And if a patient like this 48-year-old male is afraid, he does not put weight on the leg, and then you see after 3 months, this is a complete different leg. The metabolism of the bone is completely disturbed. And this is what happened to astronauts being 3 months and more in the space shuttle, coming back to Earth. They would develop such inactivity, hypertrophy of the bone. And this can result in spontaneous fractures. When they run down some steps, this would just fracture. So the most expensive workout is performed in the space shuttle because they have to do expander training to avoid that. And in Amsterdam, we have now a lab where we try, together with the space agency in Europe, if shockwave could be used prophylactically to avoid this kind of development. So mechanical transduction is practically a communication. We give an input, we just do not know the language yet, but when you are looking on the different cells, practically all cells are possible to be influenced by mechanical stimuli. And this can even result, here you see that when the wave is going through the cell membrane, it opens the door and molecules can enter that couldn't enter before the mechanical impact came. And you might remember 2 years ago, the Nobel Prize was awarded to 2 researchers that could explain how the transducers are working when you get feeling or temperature to your skin, and how it is developed that you can understand, because these receptors made it possible that we developed as humans. Because if you cannot feel your surrounding, if you cannot think this is sharp, rough, hot, cold, you cannot develop anything. And so perhaps we are even one step further, because we are using these mechano receptors to give information to the body, and the body reacts in activating genes, and these genes producing proteins, growth factors, that are responsible for the healing and regeneration. So what we know, and this is probably true for all tissues, we didn't yet prove it in all tissue, we can induce angiogenesis, which means you have pre-existent vessels and then they form new blood vessels. But, and this is due to Johannes Hohlfeld, who could prove that. He is a surgeon, a cardio surgeon in Innsbruck, that we also can stimulate vasculogenesis. And this is interesting because usually this is only possible in fetal tissue and not in grown up. And this is different because when you apply shockwave to ischemic tissue, progenitor stem cells, endothelial progenitor cells are attracted, go into this tissue, they form tubuli, and this tubuli then connects to pre-existent blood vessels. So this is a very interesting knowledge to know that we can stimulate vasculogenesis. And then we know that shock waves are modulating inflammation. It's a modulation of the inflammation. It's not anti-inflammatory, because we need inflammation for all healing processes. And shock waves are modulating them, that the acute phase is decreased and that the phase of repairing regeneration increases. So message to be taken home first is we have more blood vessels in the tissue, functioning blood vessels, not responsible for pain, not the vascularization that we see on inflamed tissue. These are not functioning blood. In the contrary, they are responsible for pain, for swelling, for reddening. So the right ones. On the other hand, we saw patients like that. This patient was scheduled for amputation due to peripheral arterial vascular disease, and he refused. And to try, he got Shockwave. And after 6 months and a couple of treatments, this was to be seen. And this cannot be explained only by more blood vessels. So as we saw it also in scar formation, we were convinced that stem cells are involved in our processes that we are creating by means of shockwave. And it's extremely difficult to prove that. And we did a trial again with Johannes Hohlfeld, where we needed fluorescent mice. You can buy them. Each cell of this mice is fluorescing in the light microscope. And then we had the wild type mice. And we exposed the wild type mice to X-rays to destroy, to harm their bone marrow. And after 4 weeks, bone marrow from these fluorescent mice was transplanted to the wild type mice that had the X-ray radiation. Then we waited for another 4 weeks and created, by ligation of a coronary artery, an infarction in these mice. And after another 4 weeks, we applied shockwave directly to the heart, to the ischemic part of the heart, where the scar was developed. And after another 4 weeks, we found functioning cardiomyocytes that were fluorescent. So we could prove that if we apply shockwave to ischemic myocardium, signals are sent to the bone marrow of these mice to stimulate, attract stem cells. These stem cells come to the place that is preconditioned by shockwaves, perform homing, and then develop cardiomyocytes, the tissue that is necessary. And this, of course, influences the function. Suddenly, this was the first time that we had the idea that we are able to regenerate heart muscle, because till today, this was not possible. The final solution always is transplantation. So this was a student that has done this. These are the proteins that are delivered when shock waves are applied to tissue through the blood vessels. This goes to the bone marrow, and from there they activate the stem cells. Just a nice small video. And this explains how patients like that react on shockwave. This is necrotic skin to be burned. This patient was scheduled for necrosectomy and then second look and skin grafting. Instead of that, he had 3 sessions of shockwave, and 3 months later, we have hair growth in this area. So this was only to be explained when we knew that there are stem cells involved in the procedure that we offer to the patient. This is from Richard Thiele. This is a decubital ulcer after 2 weeks in the hospital. She received a total knee replacement. And now, of course, the plastic surgeon said, first step is colostomy to get it clean. Then we do necrosectomy and then flap. And she refused and went to Richard Thiele. And he gave her shockwave in the beginning weekly through 2 months, and then bi-weekly. And at the end of 3 weeks, I don't think that this would be necessary, but this was how it ended. And here he took biopsies and could show that this is normal skin. You have hair follicles in it, you have all what is usual in normal skin. And this was not yet closed because this went directly to the sacrum, but this was an easy game because you just do a small flap and this is the result. So again, back to stem cells, because I think this is the main message. I was invited after the pandemic to, it was nice because it was the first time that urologists invited me, and the title of my presentation, they gave it, was very provocative. What are you orthopedics doing with our shock waves? Because the urologists consider shockwave as their because they brought it into medicine. And so I gave them an overview. I showed them a little bit what I show to you today. And then at the end, Jens Rasweiler, he was the president of the Urologic German Society. I asked him, what is your worst soft tissue problem you have in urology? And he said, this is Fournier's gangrene, because you have to take off all the necrotic stuff. And at the end, you have huge defect of soft tissue and coverage. And this needs usually a lot of plastic reconstructive surgery. And so the first 2 or 3 patients, he sent me the pictures. He just did surgery and combined it with shockwaves. And then I said, why do you just apply shockwave? And this was the first patient where he just applied shockwave, and he looks like that after 6 weeks and like that after 12 weeks. And he showed me these pictures. He said, I will publish this case because what you see is here on the scrotum, you have the shrinkle like the skin on the scrotum usually is. And on the penis, you have a flat skin like usually it is on the penis shaft. And this really shows that under the and there was no surgical procedure done. This is just shockwave, that there is a regenerative process in the tissue. So this is what we learned over the years, what shockwave do in tissue. But of course, the most important or the most impressive part is the mobilization, migration, homing, and differentiation of stem cells. And now I give you just some examples how it also can work, for instance, on scar tissue. This patient had a reduction plasty. She had 4 kids and developed a fat surrounding the belly. This is the back, and this was after 3 treatments and half a year. It looked like that. And here you see the same in the front part, and it looked like that after 6 months. But, and this was the reason for we understood that we can use shockwave also prophylactically. She had a cholecystectomy with not open. And you see, she had 3 incisions, 1 here, 1 here, and 1 here. And this was exactly where we applied shockwave. And this is practically not to be seen, the scar. And here, out of this region, we have again the hypertrophic scar as she is developing usually. So we treated now this and this scar. And another 6 months later, you see there's practically no scar formation anymore. Oh, sorry. This is also, this is when I lost a box of champagne to Carsten Knobloch, because he was convinced that this will work also on cellulite. And I thought, due to my experience, shockwave only worked in pathological tissue. It didn't change really in healthy tissue. And cellulite is healthy tissue. The pathology is just in the eye of the observer. But this is how it develops over years, the fat in female patients. And he did the study, prospective, randomized, placebo-controlled, double-blind, and he could see, yeah, also in this kind of problems, shockwave might be helpful. Meanwhile, there are, I think, 12 really serious publications on that.